just a strand or a thread which we use to ligate the vessels and to approximate the tissues together. It can be skin, it can be subcutaneous tissue, it can be muscles, it can be fascia, but we bring tissues, approximate tissues, and bring them together. The purpose is that we provide, by the time the wound starts to heal by itself, we provide, approximate them together to give them an adequate tension so that bring them, it should not be tight enough, because if it is too tight, then blood vessels will be occluded and it will cause tissue ischemia. But purpose is to bring them, approximate them together so that the healing starts. We use them for hemostasis. We ligate the blood vessels and wherever the tiny vessels are. And if we do that in the subcutaneous tissue and in the skin, we want the wound to heal by primary intention, where primary intention means healing by bringing the tissues together. Secondary, when you leave them apart, and slowly and gradually the wound starts to heal. And when if we bring the tissues together, obviously it reduces the pain and it provides support to the tissues, and it probably permits tissue flaps together are approximated. So like if we are raising flaps like abdominoplasty, like mastectomies, if we suture them, it avoids dead space. So the sutures can be used for various reasons. What is the ideal suture? Uh, Sutures have various characteristics. In some situation, we want some characteristics. In another situation, we want some other properties of the suture. So ideal sutures which we can handle very easily. It should not have tissue reaction, like silk causes severe tissue reaction. The knot tying should be easy. It should stay there for a longer period of time or as long as we need them. It should not lose its tensile strength very early. It should not cut through the tissues. It should be less allergic, flexible, easy to handle, and obviously it should be cheap. So let's see how the suture material is. It is can be very thin, that like 10 O, that we really need a microscope to see, or it can be very thick. Normally, if you see zero, the more the zeros we have, the thinner is the suture material. It's difficult to write down 10 times 0, so it's like written as 10 0. This is 4 times 0, this is 2 times 0. So 0, if you're putting down, if we go on more zeros, the suture material is getting thinner and thinner, and 10 zeros may be used for eye surgeries, and it is difficult to see them without a microscope. But if you go on the other side, from 0 onward, 1, 2, 3, the suture material is thicker and thicker, and 4 becomes like a rope, right? So generally for general surgical purposes, we use 2-0 for our bowel anastomosis, and for fine vascular anastomosis, we use 4-0-5-0. For abdominal wound closures, we go on to 1 or 0. So that's where, and for liver approximation, sometimes for larger, we need even 2 will work out. So it depends what surgery and what purpose, so you decide the thickness of your suture material. Now, how do we classify suture materials? There are various ways to classify them. They can be absorbable, non-absorbable, depending upon their tissue of origin. They can be natural or synthetic. How they are put together, is it one thread or there are multiple threads twisted together in a braid form, which is called multifilament, braided or unbraided, whether they have been dyed or coated with anything, and we'll talk about it. Now coming about to absorbable sutures, whenever they put them, they eventually get absorbed, and the absorption times depends upon suture to suture. And these are used where we need approximation for a shorter period of time, like in the subcutaneous tissue, to eliminate the dead space, and we want to minimize the tension till the wound completely heals. Where we do not want suture material to remain there and cause permanent tissue reaction like a foreign body like reaction, and this decreases the risk. We use them like absorbable sutures where we want the wound like in bowel anastomosis. Maybe we apply them on subcuticular skin where they get absorbed. We ligate suture material, the blood vessels with that. So how do we use different things accordingly? Generally, it is used for ligating blood vessels, um, bowel anastomosis, fascia anastomosis, especially smaller areas where we want to use it. And we use them for subcutaneous tissue, we use them for skin subcuticular tissues. So when we talk about absorbable sutures, the absorbable sutures themselves can come from the natural sources or they may be synthetic. Natural is catgut and synthetic can be vicryl, dexon, monocryl. We'll talk about them one by one. Catgut comes from, as the name suggests, gut of the cat. It is monofilament. Plain catgut, as it says, it gets absorbed very early in 7 to 10 days, and it is gets absorbed by phagocytosis, and it has a significant tissue reaction. So we can only use them for superficial subcutaneous tissues, right? Or for superficial well. It is no longer, catgut is no longer used. This was used definitely in my residency area when vicryl and other things, synthetic materials were not easily available. But if we treat these tissues with chromic acid, then their tensile strength is for a longer period of time. It is derived from the gut of the sheep. And now that tensile strength was there for 7 to 10 days. Now it is going up to a month, 3 to 4 weeks. And it is degraded, not early, it is degraded. It is lasting there for 6 weeks. But if we coat them with chromic acid, the tissue reaction is much more than the plain catgut. And again, I'm saying when the synthetic materials were not absorbable, were not easily available, we used to stitch gut with the chromic catgut because it would get absorbed in 6 weeks by the time the gut would get approximated together. Or maybe we would use it, the inner layer of the gut with this and outer layer with silk. But silk, on the other hand, causes severe tissue reaction. But you have a choice what is available and you try to pick up those. But nowadays, we hardly see catgut and we hardly use it. But you should know this is the natural absorbable suture material that we have. Okay, we come down to now synthetic suture materials, and we have few, and more or less their strength is, and the properties are the same. We commonly, if you go to our ORs, we see vicryl, and the chemical name is polygalactin, and it is multifilament. Multifilament, the thing is, it is easy to apply a knot over there. It does not slip. Like if you are tying a knot with your one hair versus an entire braid, the braided would last there. The bunch of the fine threads will have a more secure knot. It has a tensile strength there for weeks and it gets absorbed again in 6 weeks time. Nowadays, this is the one of the most commonly used suture material. We use them for gut anastomosis. Even if we are using 2 layers, we use both the layers with vicryl. We ligate vessels, and it causes less tissue reaction. That's the reason it is more commonly available. It is used almost in every surgery. and subcutaneous tissues, and even for skin closures we are using them. But this vicryl is also whether it is dyed or undyed. The dyed, wherever it is coated or dyed, it has more tissue reaction. So if we are using skin with dyed, which is violet or purple in color, the tissue reaction is more. So for skin, we use undyed vicryl, which is white, and it causes less tissue reaction. So we use subcuticular skin suturing with undyed vicryl. So other suture material again is polyglycolic acid, Dexon. It has the same synthetic, multifilament synthetic. It again can be dyed, undyed, coated, uncoated. And its tensile strength is also there for about 2 to 3 weeks. It gets absorbed in again 6 weeks time, and obviously it has the same indications where we want completely suture material to be used, like mainly we use it proline for the abdominal wound closures. We try to avoid putting absorbable suture materials there because we want the abdominal wound to be approximated for a longer period of time. Monocryl is synthetic, but apart like Dexon and Vicryl, this is monocryl is monofilament. So the monofilament tissues, they glide through the tissues very easily. The multifilament glide through the tissue with difficulty. So on one hand, it is glides through the tissues very easily. So whatever it goes through easily, it is difficult to secure a good knot. So if you are tying a knot with your one hair, it will be very difficult. So you need to apply multiple tile. That's the reason wherever we used monofilament suture material, we do not rely on 3 or 4 knots. We go on 9 or 11 knots. Like proline is a monofilament. We apply 9 to 11 knots. But proline is non-absorbable. Monocryl is absorbable monofilament. So whenever we want to use tissues, quickly want to run through the tissues, like if we have raised big flaps and we want tissues to be approximated, rather than tying knot with every suture, you can glide through the tissues easily. For multifilament, sometimes we have to apply polyfix or something so that it passes through the tissues easily. So monofilament has the thing that it passes through the tissues easily. It has the absorption time 6 to 8 weeks, and this is used in subcuticular skin, in GI or muscle surgery. But be sure that we pull it adequate enough that we do not lose that strength of it. If we let the skin go loose, or especially if we are using it for GI, then probably one has to, it is better to use multifilament rather than monofilament if you cannot pull the tissues thread adequately. Other thing is polydioxanone PDS. Its absorption time is longer. It is also monofilament, but indication are more or less same like monocryl. So from the absorbable suture material, we have multifilament, and if you remember, the multifilament are vicryl, and multifilament is Dexon or polyglycolic acid, and the absorption time is 60 to 90 days. And we use it where we want the tissues to be approximated for a longer period of time. And we use it for gut anastomosis, for facial anastomosis, for thin fascia. We use it for subcutaneous tissues where we raise flaps, and for skin closures. Monocryl and PDS are monofilament absorbable suture materials. Their absorption time is 6 to 8 weeks, and they can be used for subcutaneous tissues or for skin where we want the things to glide through easily. We can use it for continuous sutures as well. Now come down to non-absorbable suture materials. where we use non-absorbable suture materials, where we want the wounds to be approximated for a longer period of time, where we want the tensile strength of the tissues to be there for a longer period of time. So obviously for vascular anastomosis, we do not want the suture material to be absorbed where our vessels have not completely healed together. So for all vascular anastomosis, for our hernias, for our midnight laparotomy wounds, for tendon repairs, we want the tissues to remain there. So we use non-absorbable suture materials there. And again, non-absorbable suture materials can be natural and can be synthetic like absorbable suture materials. In non-absorbable suture material, natural is silk and linen. And from synthetic non-absorb, we have nylon, proline, dacron. So let's see what are these. Silk comes from silkworms. The girls must be knowing that we wear a lot of silk clothes. It is natural, but remains there, so tensile strength is there for much longer period of time, up to 6 months, and it remains there for years, 1 to 2 years, and then slowly. But the side part is it causes severe tissue reaction. If you have ligated the vessels with silk, or you have used gut anastomosis outer layer with silk, in those era when I was being trained, ancient time, then it once you had to go back on that abdomen, there was so much adhesions among the tissues that it was difficult to go through the same area. So it causes severe tissue reaction. And we used to put it still because we did not have the luxury of the synthetic suture materials that we had now. And obviously, we cannot use it where we are using prosthesis because it causes tissue reaction. And wherever there's severe tissue reaction, there will always be a risk of infection. So do not use them wherever we are using implants, meshes, or other suture material, the vascular suture material. The linen is again, it is a natural, and we use them. It is non-absorbable, and this causes also moderate tissue reaction. And it was used in GI surgeries. It is not used much commonly in here. So we have two natural. There is a steel available. It is monofilament, and this is used whenever we are like to bringing the bones together, like the people who go for bypass where you have to do a sternotomy, use steel wires to bring the bones together. And we want obviously the bones to be there till they have joined together. And it has a minimal tissue reaction, the steel, and it does not harbor bacteria. And as we said, it is used for in olden days it was used for repair of hernias because silk was not considered appropriate. So people were at those times repairing uh, um, hernias with steel. But now we have meshes available and we have proline available, so we are not using steel wires for the repair of hernias. Nylon is synthetic. It can be available in both. It wherever it has gone there, it remains there, and it causes very little tissue reaction and not security, especially if it is monofilament. Obviously, you have to tie multiple knots. Stainless steel is monofilament. It is the strongest, and the knot security is good because wherever you twist the knot, it stays there. It is difficult to handle because you are handling with a wire, and if it can easily, it is strong, so it can easily cut through that. When you are tying it off, it cuts through the tissues, and tissues does not bring the muscle or other tissues together. For bones, it is difficult to cut it through. um, Nylon, as we talked about it, it stays there for a longer period of time. It has been used, or it is still used for abdominal wound closures. It is monofilament, and so it is easily to glide through tissues, and it causes less tissue reaction. So it acts like, it's almost the same characteristics like proline. Um, Dacron is mainly available in mono and multifilament both, and it is used for cardiovascular surgeries, ophthalmoplastic, and that can be used for general surgery. And we use them for our main abdominal wound closures, our hernias closure, because we want the tissues to be there. This is the most other commonly used suture material, proline. It is monofilament, and it is non-absorbable, and it has a very low tissue reaction. But again, as we said, it is monofilament, so it is glides through the tissues very easily, but knot tying is difficult, so you have to apply many knots to secure your knots together. So 9 to 11. Monofilament sutures, as we said, they pass through the tissues smoothly, minimal tissue reaction, but they can be damaged easily. So if you apply, you bend them completely, you apply your artery forceps on the suture, they break. And once they break, then probably they lose their strength completely. So applying you, and on the same artery forceps, if you apply on vicryl or multifilament, they do not fracture. Monofilament suture materials can fracture. So you have to take this thing in your mind when you are taking handling these tissues, that you do not apply artery forceps or fracture them. So one has to be very careful in dealing with them. Multifilament, there's a friction in passing through the tissues, but knots are very secure easily. So when we were saying multifilament, we understood that they're easy to handle. They drag through the tissues. Because of multifilament, they can harbor bacteria. They're not, security is very good, and they do have a slight tissue reaction. If we compare it with monofilament, if you fracture them, they remember it. They pass through the tissues easily. They do not harbor bacteria. The tissue knot security is not very good, and they have almost negligible tissue reaction. So we have to select where we are using monofilament versus multifilament. We do not have to remove sutures like absorbable suture materials, and we only remove suture materials which are subcutaneous suture materials. And we can use proline for subcuticular suture material, and we can use, like, apply them on our face, ears. We can use interrupted suture materials with proline, especially because tissue reaction is less. So we can literally use them and remove them in, because face has a very, very good vascularity. We can remove suture materials in 3-4 days, and it causes less tissue reaction. So this is one of the very good suture material for skin closures, lacerations on the face and neck area. Uh, we remove them in 7 to 10 days time, and they can be used for skin closures. Like in olden days, I keep remembering the suture material used was silk. it causes severe tissue reaction. We use proline to fix our drains now on the skin. So this is the proline is the favorite suture material for skin closures, and we remove them in 7 to 10 days time. If we leave them longer, the knot sometimes can cause reaction. Like if the patient is thin and lean, and we have used proline for abdominal wound closures, and we do not hide the knot inside the abdomen, and knot is lying in the subcutaneous tissue, then that thread can peep in and irritate the skin, and patient gets a little sinus. So until unless you go back and remove that knot, obviously after adequate time, once the wound is completely healed, then you have to end up doing that. So for proline or monofilament, non-absorbable, you have to hide your knot somewhere under the abdominal wall or in the subcutaneous, so that your knot is there to irritate the skin constantly. And sometimes when we use fine threads, it is difficult to see them. So you remove the sutures and patient is very grateful. And then after some time, patient says this wound is not really, there's constant discharge. And then you have a look at the wound, you see one suture you forgot to remove. So when we are using fine sutures, one has to be careful. And if you count while you are putting them, and you just see them or have a good look at them with a magnifying lens, especially when you are using fine sutures, that does help. Now coming back to the needles that we use. There are various kinds of needles that we have. We have straight needles, we have curved needles. And if you see, the curve also has the different large curve, thin curve, so how wide it is. And if you see the tip of the curve, can you see this? This has that sharp curve tip, and it is the body is triangular. If you see it's a sharp tip, the body of the needle is rounded. If you see the sharp is here, it is triangular here, then it is rounded at the top. And if you see here, it is sharp here, triangular here, and then rounded at the top. And if you see that even the tip is rounded, so we call it is a cutting needle. If these sharp things goes and the entirely it is cut, which is a cutting needle, and we say it is round body needle, or we say it is partly cutting and partly round bodied needle. And there are different indications for that. When we are going through the skin, if you try to put a this through the skin, you will be really struggling every time you are going through the skin. So for skin, we need cutting needles. And when we are going through like gut, we do not want the cutting needles, we want the round bodied needles. So we use round needles. So we select our needles, what we are suturing. So blunt-ended, round-bodied needles are used for closing major incisions, and like it has low tissue penetrance, right? So we use it for, as I said, for gut, for other deeper tissues, for softer tissues. And this is what blunt-ended. Round-bodied, we use it for when we have to use for a, partly it is sharp, partly it is not. So sharp pointed but smooth round, what we were talking about, these needles, they have a sharp tip, but the body is rounded. We are using them for so that we push through the tissues easily, but then we go through the this like bowel and blood vessels. This we use for closing major incisions. Cutting, we use it mainly for skin closures. Now coming down to sutures, after that we come down to drains. Drains are a wide variety where we want to use, where we do not want the fluid to be remain there, and we want the fluid, that fluid can be pus, a serous fluid, can urine, or blood, anything to come out from the body or from the cavity, and we do not leave the thing there. So indications of using a drain are that we encourage drainage of pus from an abscess without allowing premature closure of the overlying wound. And if there is drain, the cavity will keep on shrinking easily, and it facilitates wound healing. We use them so that the fluid does not remain there in any cavity, and we have done a laparotomy, and pelvis being the dependent part, we put a drain there, so whatever fluid is, it comes out of the abdominal cavity, and we allow the drainage of contents from the hollow organs post-operatively, like we are using from in the whenever we do a choledochotomy for removing stones from the common duct, we use a T-tube drainage, and we are removing fluid from the pleural cavity, we put test tube drainage. We are removing fluid from the stomach, nasogastric tube. We are removing fluid from the bladder, we use Foley's catheter. These are all the varieties of the drains, right? And we want to use it where we are not too sure whether there is anything or not, so we put them that if there is any complications, like suppose we have done a cholecystectomy, we have secured, but maybe we are thinking there was some oozing from the gallbladder bed, or you think the patient has severe empyema gallbladder and there might be an infection and food collection, you want a drain so that you continue to see that if there is any leakage, you might be able to aspirate it. And it can be used in an abscess cavities for an irrigation also. Whenever there is a bladder repair and you are scared that your bladder might leak, you put a drain not only in the bladder, but you put it in a perivesical space. So there is, if some urine leak, you are able to drain that. And you put them in the fistulas, wherever you have repaired that the fluid keeps coming out of it. So you put the drains wherever you do not want the fluid to get collected, because if the fluid keeps on coming out, the cavity gradually shrinks down. So disadvantage is it, okay, obviously it is open, one end is open out, so there is a chance of infection, and you are making additional skin opening, and it might interfere because of infection, it might increase inflammation. I can give you an example that when we use mastectomy, you want the skin flaps to be approximated. So we put the drains there, but obviously the seroma keeps coming out. So you have to empty the bottle. So whenever you are emptying the bottle, you are opening it to the atmosphere. You may be using sterile techniques or not. So you are exposing the wound to have infection. And if you leave the drain, or you are forced to leave the drain there for a longer period of time, then probably there is risk of infection and wounds get infected in that way. So the drains can be corrugated drains, where it's like one ridge is elevated, one is dipping down, one is elevated, one is dipping down. So the fluid, if you open them in a deep cavity, like you have a perianal deep abscess, and it is difficult for you to pack the wound deep down, then you put this like a pipe, sort long pipe, or it can use can be silicone latex thing, and you put it and stitch it up so the fluid does not go deep down and fluid keeps coming out. So that is, you have abscess cavity, you have left it, but it is difficult to pack the wound deep down. So you put down the Penrose drain or a corrugated drain, and the fluid keeps coming out. The We can use alternatively, if you use a tube drain like a nasogastric tube, uh, we can put down the tube drains, but it has few holes. It has a complete ridge, so it is easily to take the things out. Sometimes when corrugated drains are not available, we take a nasogastric tube, make a slit in it long enough, and take a piece out, so then it becomes a tunnel where that fluid can be drained out easily. This is how the corrugated drains are, that it has an elevation. It is like a piece. You can cut it if the wound is thin. It has one edge elevated, and there's a dip, and then elevation and dip, and fluid keeps coming out through the the depressed areas. And we suture them and keep pulling the drain out slowly so that the top starts to heal easily. The tube drains, again, it can be have this bottle. It has small, tiny openings in the entire wound. You may not have tiny openings in the entire wound. You can have only openings in the tip, like in the nasogastric tube. This has a suction or a vacuum to it. The tube drains can be without the vacuum. You can connect it to the bags like a urine bag, nasogastric bags. You can do that also. And it is used for shorter period of time. Advantages of tube drains over corrugated drains. The corrugated drains is an open drain. The tube drains can be collected, so they have less chances of infection. Corrugated drains we prefer to use them for an infected cavities. The tube drains we use for sterile areas like in the abdominal cavity, like for urine, for stomach drainage, and there are less chances of infection traveling to these areas, and it is a closed system. Suction drain, vacuum drain, or ready-weight drain is the same name, right? And because of it has a negative pressure, so it pulls the tissues. It is not dependent on the gravity like the tube drains. So it forces the tissues, because of negative pressure, to approximate together. It is used for cavities like mastectomy cavities, like flaps we have those. We are using latissimus dorsi to bring it together. So if you use huge flaps, you need negative pressure to bring them. You have repaired a large abdominal hernia, you want a suction drain or a negative drain to bring the abdominal flaps and adhere it to the deep fascia down there. Or you want there should be no blood there, so you use suction drains, ready weight drain, vacuum drains, negative pressure drains. These is the one and the same name of the same kind of drains. So if you see the suction drains, this is one of the thing, that if there is a negative pressure, then this green top remains sinked down, and you can see the fluid is collecting there. There is another bottle which which you can collapse, and that can, if it is collapsed, you can see that's a silicone one, that it has a negative pressure, because if there is no negative pressure and this green thing pops off, then probably the negative pressure is gone. It is like a gravity drain. So you have to change the bottle so that there's a negative pressure and the purpose is served. This bottle is an underwater seal, or it is used for chest drain. The chest drain, the tube is different. It has multiple holes, and usually there is a mark where the last hole is and how far it is from there, because when you are, it has a sharp, it is obliquely cut posterior end, and the front has a rounded blunt. It has 4 or 5 holes at the various sides. We make sure then we are putting it, all the holes are inside the pleural cavity. because if one of the holes is not, it will not create a suction here. The air will peep outside, the column will not move, and if one of the holes is in the chest wall, then obviously it will leak, the air will leak into the chest wall and it will cause subcutaneous air collection, which is called subcutaneous emphysema. So you make sure that all the holes are inside the pleural cavity and you are there outside. So you mark how far do you want to go inside the pleural cavity, and then you connect other end of the chest tube to a underwater seal. And if you see them, we connect it to this tubing. It has a tube, this is connected to the tube and that has a long tube. It is going down to the base of the bottle, and we fill this part of this bottle with the water, and it has another tubing here which is just lying up here. This does not sink into the water. This equalizes the pressure with the atmosphere. So whatever fluid we take, that fluid goes from this tube through this tube to, it is connected to this tube which is dipping down into the tube which is immersed in the water, and this is the another open portal here which is connected to the atmosphere, so that this equalizes this pressure with the atmosphere, because normal pleural cavity pressure is a negative pressure. So this fluid, it equalizes the pressure so that fluid in the pleural cavity comes and collects here. As soon as this starts to fill and it is coming touching air, we need to change the bottle so that this tube does not, this small tube does not sink in the water that we are collecting, this chest water bottle, which is called underwater seal drainage. This is the tube that we were talking about, tube drainage. It is available. The red is a 16, 18 gauge. The 18, 16 is orange. It is available in different color depending upon the size. And we put in children small 5, 10 sizes when the tube is thinner. As the size gets bigger, 23, 24, it is large, thick tubes. We connect them to the drainage bag. This is the same drainage bag used for nasogastric tubes and for drainage of the Foley's catheter. So Foley's is made of latex. It can be used of silicone, which can be used for a longer period of time. Has a bulb at the tip. So in order to, we want the Foley's to remain in the urinary bladder. So we fill it with the water, not with the saline, because saline crystallizes, and no matter you want to take them out, it will be difficult to deflate the balloon and you cannot then take them out. So you always fill the balloon with the distilled water, and this is the portal where it has a thin, this, can you see the red thing? We fill it with the distilled water and it inflates the balloon there. Every size has a number written on it, what is the maximum strength. You check the balloon before you put the Foley's catheter in, that the balloon is intact. Small children, 5 to 10 cc's we do. For the larger sizes, you may go up to even 25, 30. But the balloon, on the catheter, it is written what is the capacity of the balloon. If you overinflate, it may burst. If you underinflate, it might easily come out of the urethra and may damage the urethra. And it can have, we connect this portal. It has a larger with the bag. Can be double lumen, can be 3 lumen. That it has open, not one but 2 portals. So we connect this with the urine bag, and we use third portal for irrigation. Like we are using, there are a lot of bladder is oozy and there are a lot of clots. You want to irrigate. Do not want the blood clots to remain there. So you connect the third portal with the normal saline, and now you are irrigating the bladder. So bladder, on one side the fluid is going out, and on other side it is irrigating and coming out into the bag. So you are irrigating the urinary bladder. This is the chest water drain. You can connect it. It is available in various sizes. This we talked about the ready wag drain or suction drain. The tubing is different. It is stiff. It is available also in various sizes. Here also you make sure that all your holes are inside the flap in the body cavity. If one of the holes remain outside the body cavity, then you cannot have the vacuum or negative pressure here. Other tubes can be endotracheal tube, and it also has a balloon, and we ensure that it is inside enough that it is in the main bronchus, not it can glide through to the right main bronchus, and then it will only inflate the right lung. So we auscultate both the sides when we put the endotracheal tube in, that it is the both the lungs are inflated. uh, when we are putting it for the tube drainage, it should preferably put in the dependent part and shortest possible route where there are less chances of kinking and obstruction. And we can put it through the main wound, but it is better to put it through another separate stab wound. We secure them. We secure them with preferably suture material which is less causing less reaction, and you can leave them for as long as the tube you want the tube to serve its function, and then you remove it. If there are any questions, I will be happy to